Good morning, ladies and gentlemen. I am Dr. Armen, Professor Armen Astvatsatryan from Yerevan, Armenia, and today we will talk about complications of acute myocardial infarction. So actually this is the same as the complications of acute coronary syndrome, the same chain. Numerous complications occur as a result of a myocardial infarction and increased morbidity and mortality. Complications can be roughly categorized as electrical dysfunction, conduction disturbance, arrhythmias, mechanical dysfunction, heart failure, myocardial rupture, papillary muscle dysfunction, thrombotic recurrent coronary ischemia, mitral thrombosis, inflammatory complications, pericarditis, post-myocardial infarction syndrome. And let's start with electrical. Electrical dysfunction occurs in more than 90% of myocardial infarction, almost always. Electrical dysfunction that commonly causes mortality in the first 72 hours includes tachycardia from any focus, rapid enough to reduce cardiac output and lower blood pressure, Mobitz type second block, the second degree of course, or complete AV block, atrioventricular tachycardia and ventricular fibrillation. Asystole is uncommon except as a terminal manifestation of progressive left ventricle heart failure and shock. Patients with disturbances in cardiac rhythm are evaluated for hypoxia and electrolyte abnormalities, which can be causative or contributory. So, sinus node disturbances. If the artery supplying the sinus node is affected by an acute coronary syndrome, sinus node disturbances can occur. They are more likely if there is a pre-existing sinus node disorder, common among older patients. Sinus bradycardia. Sinus bradycardia, the most common cause sinus node disturbance, is usually not treated unless there is a hypertension or the heart rate is less than 50 beats per minute. A lower heart rate, if not extreme, means reduced cardiac workload and possibly reduced infarct size between us. For bradycardia, which hypertension, which may reduce myocardial perfusion, atropine sulfate 0.5 to 1 milligram intravenous is used. It can be repeated after several minutes if response is inadequate. Several small doses are best because high dose may induce tachycardia. Occasionally and temporarily, transvenous pacemaker must be inserted. Why not? But temporarily, of course. Now about sinus tachycardia. Sinus tachy. Tachy, like taxi. Yeah. Actually the same word, taxi and tachy. So persistent sinus tachycardia is usually ominous. Very ominous. Often reflecting left ventricle heart failure and low cardiac output. Without heart failure or another evident cause, sinus tachycardia may respond in a very good manner to a beta blocker, given orally or intravenously, depending on degree of urgency. Atrial arrhythmias. Okay, about atrial arrhythmias. Atrial arrhythmias, for example, atrial ectopic beats, atrial fibrillation, and less commonly atrial flutter occur in about 10% of patients who have had myocardial infarction and may reflect left ventricle failure or right atrial infarction. Paroxysmal atrial tachycardia is uncommon and usually occurs in patients who have had previous episodes of it. Atrial ectopy is usually benign, but its frequency increases. Causes, particularly heart failure, are sought. Frequent atrial ectopic beats may respond to a beta blocker. Now about atrial fibrillation. Actually, about atrial fibrillation we have had, as I know, one lecture, right? Okay, so atrial fibrillation is usually, well, I will give a link. Okay, atrial fibrillation is usually transient if it occurs within the first 24 hours. Risk factors include age more than 70, heart failure, previous history of myocardial infarction, large anterior infarction, atrial infarction, pericarditis, hypokalemia, hypomagnesemia, and chronic lung disorder and hypoxia. Please show one of atrial fibrillation. I will show you in my manner. Of course, it's not a good manner, it's not a good quality, but if you've got some problems, you can put on pause. You can see absence of P wave, because this is atrial fibrillation. Okay. Okay, fibrinolytics reduce incidence. Recurrent paroxysmal atrial fibrillation is a poor prognostic sign and increases the risk of systemic emboli. For atrial fibrillation, and heparin, unfractionated or low molecular weight, is usually used because systemic emboli are a risk. Intravenous beta blockers, atenolol, for example, 2.5 to 5 milligram over 2 minutes to a total dose 10 milligram in 10 to 15 minutes, metoprolol 2 to 5 milligram every 2 to 5 minutes to a total dose of 50 milligram in 10 to 50 minutes, or either beta blockers, rapidly slow the ventricular rate and are typically given when heart rate is more than 100. Heart rate and blood pressure are closely monitored. Treatment is withheld when ventricular rate decreases satisfactorily or systolic blood pressure is less than 100 millimeter hydrargyl. Intravenous digoxin, which is not as effective as the beta blockers, is used cautiously and only in patients with atrial fibrillation and left ventricle systolic dysfunction. Usually digoxin takes at least 2 hours to effectively slow heart rate and may rarely aggravate ischemia in patients with recent acute myocardial infarction. For patients without evident left ventricle systolic dysfunction or conduction delay manifested by a wide QRS complex, the intravenous calcium channel blockers, verapamil or diltiazem, may be used for rate control when beta blockers are contraindicated or if adequate ventricular rate control is not achieved with other agents. Diltiazem may be given as continuous intravenous infusion to control heart rate for long periods. Intravenous amiodarone may also be used for treatment of acute atrial fibrillation, especially in settings where intravenous beta blockers or calcium channel blockade is not appropriate or contraindicated, such as with low blood pressure active asthma. Due to a high risk of recurrent atrial fibrillation in patients with acute myocardial infarction, an initial cardioversion strategy may not be preferred. If atrial fibrillation compromises circulatory status, for example, causing left ventricle failure, hypertension, or chest pain, urgent electrical synchronized cardioversion is done. If atrial fibrillation returns after cardioversion, intravenous amiodarone should be considered for patients who continue to experience symptoms, for example chest pain, or remain hemodynamically compromised. Atrial flutter. For atrial flutter, rate is controlled for atrial fibrillation. A heparin infraction or low molecular weight is required because the risk of thromboembolism is similar to that with atrial fibrillation. So rate control for atrial flutter in patients with acute myocardial infarction is usually unsatisfactory. So low energy direct current synchronized cardioversion will usually terminate atrial flutter. So once again, okay, let's show you. Okay, I will show you in my manner, of course, this atrial flutter. So if you've got some problems, we can put on pause to see in better quality. Okay, this is atrial flutter. You see? This is atrial flutter. Flutter waves. Like sword, huh? Yeah. Teeth of dragon or crocodile. Yes. This is classic atrial flutter. Not so common, huh? Between us. Okay, so conduction defects. Mobis type 1 block to second block. Second block, we know that AV block got second type, got two subtypes. So Mobis type 1 block, Wenkenbach block, progressively prolongation of PR interval with eventual dropped beats, is relatively common with an inferior diaphragmatic infarction, and Mobis, it's usually self-limited and rarely progressive to higher grade block. So why to not to yes, Mobis 1. Let's show us. I will show you. Okay, in my manner once again. We can put pause on this. So the PR interval progressively lengthens with each beat until the atrial impulse is not conducted and the QRS complex is dropped or escaped. So-called Wenkenbach phenomenon. AV nodal conduction resumes with the next beat and the sequence repeated. Okay, let's show you Mobis 1. Okay, this is 1P. You see it? Interval, then prolongation of this PQ, and we see P and escape, PT actually, but this is P, and escape, and sequence repeated, all this picture repeated. Once again P and dropped or escaped QRS complex, so called Wenkenbach phenomenon. Okay, so Mobis type 2 block, dropped beats, usually indicates massive anterior myocardial infarction as those complete heart block with wide QRS complexes. Atrial impulses do not reach the ventricle. Both are uncommon. So Mobis 2, difference between Mobis 1 and Mobis 2, so the PR or PQ interval are constant and then escape. So we see P and no QRS. Frequency of third degree antiventricular block or complete block depends on site of infarction. Complete AV block occurs in 5 to 10% of patients with inferior infarction and usually transient. It occurs in less than 5% with uncomplicated anterior infarction, but in up to 26% of those with right bundle branch block and left posterior hemi block. Even transient complete AV block with an anterior myocardial infarction is an indication even transient complete AV block with an anterior myocardial infarction is an indication for permanent pacemaker insertion because the risk of sudden death without pacing is significant. Okay, I show you this AV block. Okay, once again, in my manner. Okay, you see, third degree AV block. We see P, 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 and QRS. Much frequent PP and less QRS. Why? Because this is urgent situation. We see that two pacemakers, natural pacemakers, work at the same time, and sinoatrial node and AV node. So 1, 2, 3, 4. Also, actually, we see P, P, P intervals much frequent, then QRS interval. But QRS interval are equal, and PP interval are equal, but no relationship with P and QRS. This is complete block. I decided to show you one Mobis second degree, Mobis type 2 second degree. You see PQ interval equal and drop of QRS. We see PP interval and drop of QRS or escape. Okay, we can put on pause. PQ interval are constant. So PR interval remains constant, and AV Mobis type 2 second degree AV block beats are intermittently non-conducted, and QRS complexes dropped, as you see, and in a repeating cycle of every third 3 to 1 or 4 to 1 block P wave. Okay, so actually treating of heart block following myocardial infarction, Mobis type 1 block usually doesn't warrant treatment. For true Mobis type 2 block with dropped beats, or for AV block with slow wide QRS complexes, temporarily transvenous pacing is the treatment of choice. External pacing can be used until a temporary transvenous pacemaker can be placed. A permanent pacemaker is required for patients with third degree block and those with persistent second degree AV block, especially if symptomatic. Although isoprotenolol infusion may restore rhythm and rate temporarily, it's not used because it increases oxygen demand and risk of rhythm abnormalities. Atropine 0.5 milligram intravenous every 3 to 5 minutes to a total dose of 2 milligrams may be useful for narrow complex AV block with a slow ventricular rate, but it's not recommended for new wide complex AV block. Now, ventricular arrhythmias. Ventricular arrhythmias are common and may result from hypoxia, electrolyte imbalance, hypokalemia, possibly hypomagnesemia, or sympathetic overactivity in ischemic cells adjacent to infarcted tissue, which is not electrically active. Treatable causes of ventricular arrhythmias are sought and corrected. Serum potassium should be kept above 0.0 millimole liter. Intravenous potassium chloride is recommended, usually 10 millimole hour. Can be infused, but for severe hypokalemia, so potassium level less than 2.5 millimole liter, 20 to 40 millimole liter hour can be infused through a ventricular venous line. Ventricular ectopic beats, which are common after myocardial infarction, do not warrant specific treatment. And intravenous beta blocker early in myocardial infarction followed by continued oral beta blockers reduces the incidence of ventricular arrhythmias, including ventricular fibrillation, ventricular, and mortality in patients who do not have heart failure or hypertension. Prophylaxis with other drugs, for example lidocaine, increases mortality risk and is not recommended. After the acute phase, the presence of complex ventricular arrhythmias or non-sustained ventricular tachycardia, especially with significant left ventricular systolic dysfunction, increases mortality risk. An implantable cardioverter defibrillator should be considered as indicated when the left ventricle ejection fraction is less than 35%. Programmed endocardial stimulation can help select the most effective arrhythmias or determine the need for an implantable cardioverter defibrillator. Before treatment with an antiarrhythmic or implantable cardioverter defibrillator (ICD), coronary angiography and other tests are done to look for recurrent myocardial ischemia, which may require a percutaneous coronary intervention or coronary artery bypass grafting. Ventricular tachycardia. Non-sustained ventricular tachycardia, so less than 30 seconds, and even sustained slow ventricular tachycardia, accelerated idioventricular rhythm, without hemodynamic instability do not usually require treatment in the first 24 to 48 hours. Synchronized cardioversion is done for polymorphic ventricular tachycardia, sustained more than 30 seconds monomorphic ventricular tachycardia, any ventricular tachycardia with symptoms of instability, for example heart failure, hypertension, chest pain. Ventricular tachycardia without hemodynamic instability may be treated with intravenous lidocaine, procainamide, or amiodarone. Some clinicians also treat complex ventricular arrhythmias with magnesium sulfate, 2 grams intravenous over 5 minutes, whether or not serum magnesium level is low. Ventricular tachycardia may occur months after myocardial infarction, and late ventricular tachycardia is more likely to occur in patients with transmural infarction and not to be sustained. I'll show you broad QRS duration, broad QRS ventricular tachycardia. The QRS duration is 160 milliseconds. An independent P wave can be seen in second arrows. I will show you. There is a leftward mean frontal axis shift. Yes? Yes. Okay, let's show. Okay. Broad ventricular tachycardia. So once again, if you've got problem, you can put on pause this presentation to see more carefully. Voila, a broad QRS ventricular tachycardia. You see rhythm strip with P. This is second lead. Okay, P, and this is ventricular aberrant ventricular tachycardia. That's complete block. Bundle branch block, of course, left bundle branch block. You see this. Ventricular tachycardia with broad ventricular, as a bundle branch block. Broad QRS ventricular tachycardia. And for example, we see ventricular